Dear Chairman, dear colleagues, thank you very much for the opportunity to be here today. I'm very happy to present a part of my doctoral thesis with the title Association between Blood Pressure, Brain Lesions, and Cognitive Function in Patients with Atrial Fibrillation. Let's start with some background information. Atrial fibrillation is the most common cardiac arrhythmia, affecting up to 1 out of 3 individuals. Also, hypertension is a very common condition with a global burden that reached 1 billion people in 2019 and representing a leading modifiable cause of premature death. Both conditions are known to increase the risk of brain lesions and cognitive impairment, and a cross-sectional study in patients with atrial fibrillation had already shown an association between blood pressure levels and brain lesions. Considering the high frequency of both atrial fibrillation and hypertension and the increasing global incidence of dementia, a better understanding of their longitudinal association may be relevant. The aim of this study is to assess the impact of blood pressure on presence and volume of new brain lesions after 2 years and on cognitive function over 7 years. Today, I won't speak about the cognition part because it's still work in progress. Patients selected for this analysis were enrolled in the Swiss atrial fibrillation study, a prospective ongoing cohort study that enrolled 2,415 patients across 14 centers in Switzerland. Patients are seen each year, and at each visit, we perform cognitive testing and collected several clinical variables. At baseline and after 2 years, we also performed brain MRI, standardized brain MRI. For this analysis, we only included patients with available blood pressure measurement at baseline, as well as data from brain MRI at baseline and after 2 years. Patients also had information about cognitive assessment at baseline at least one cognition follow-up over 7 years. Our main predictor was continuous systolic blood pressure, but we also categorized blood pressure according to the European Society of Cardiology guidelines of 2018. Our main outcomes were new lesions after 2 years. We define new lesions as actual new lesions, but also lesions already present at baseline, but with an increased volume after 2 years. Relevant findings were ischemic lesions, which comprehended large or small infarcts involving or not involving the cortex, and white matter lesions. For our statistical analysis, we performed logistic regression analysis to assess the association between blood pressure and presence of the lesions, and linear regression analysis for the volume of the lesions. Let's jump to the result. We enrolled 1,213 patients. 74% were male with a mean age of 71 years. Mean Shadwell score was 3 points, and mean blood pressure was 135/79. 90% of our patients were on oral anticoagulation. At baseline, 35% of patients had ischemic lesions, and almost everyone had white matter lesions. After 2 years, 5% of the patients had new or enlarged ischemic lesions, and 18% had new or enlarged white matter lesion. You can find here a bar chart of the prevalence of the ischemic and white matter lesion over the different blood pressure categories. Here, we couldn't find any significant difference among blood pressure categories. You can see here 2 forest plots for the multivariable adjusted logistic and linear regression model for prevalence and volume of the lesion. Here you can see the odds ratio, and here the beta coefficients with their confidence interval. Adjusting variables were, among others, age, sex, several comorbidities, and oral anticoagulation. We couldn't find any significant association between continuous systolic blood pressure and presence and volume of the lesions, but also across increasing blood pressure categories, using optimal blood pressure as our reference. Let's just pick an example to clarify it. Patients with hypertension grade 2 or 3 had an odds ratio of 2.18 compared to patients with optimal blood pressure. for having new ischemic lesions. Considering that the confidence interval also include 1 and the p-value was greater than 0.05, this results weren't statistically significant. Very similar results could also be found for new white matter lesions. Strengths of this study are the detailed patient's characterization, the large amount of data available, and also the standardized brain MRI we performed. On the other end, main limitations are the unclear generalizability due to the inclusion criteria and also the residual confounding due to the study design. To sum up, we couldn't find any significant association between baseline blood pressure level with new ischemic lesion or new white matter lesion after 2 years. It could sound like good news. However, a long-term follow-up is still warranted to determine the impact of blood pressure on the development of new brain lesion after 2 years, or after a longer period of time, in patients with atrial fibrillation. Thank you very much for your attention.
Thank you for these very interesting results. How to measure cognitive function by mini-medal or other tests? Cognitive function.
For cognitive function, we mainly use the MoCA score, but we also perform tests for semantic fluency, digit substitution, symbol substitution test, and yeah.
The other point is that cognitive function is related with low patient compliance to the treatment. There is a vicious cycle that leads possibly to ineffective medication in these patients due to low compliance in medications. Is there any thought about that?
That's a very good question, and it's a very interesting point. Not really. We don't have any information about compliance of the patient. Yeah, we can ask the patient if they take the medication, but it's very not a stable answer. But it's a very interesting point that we can thought about development, and a good question.
Okay, there is also a question here. Joseph.
Just a comment. The statement that there is no relation with this blood pressure is a little bit strong, because I think the hypertension 2 and 3, usually there are not many patients with these categories, and probably the tendency was very clear with the wide standard deviation, but I think the series is larger with more patients with grade 2 and 3. This will be significant for sure.
Thank you for this this comment. Yeah, it's true. I can only say that in this cohort we couldn't find significant association, but yeah.
Okay, one final question here.
Yeah, so I mean, there is an association with high blood pressure and brain ischemia. I mean, if you give angiotensin receptor blocker, it will prevent stroke and ischemic event. Do you think that the reason you don't see any association is because you take your patient too late, meaning that their organism had time to adapt to the high pressure regimen and therefore is less susceptible to mismatch between blood pressure and the vasculature?
I'm not sure that I understood the question, sorry. But I think we didn't see any significant association, maybe because 2 years are just not enough to see this significant change in the volume in the incidence of new lesions.
Okay, thank you very much.